All right, I am back. Plenary session, virtual edition, and I'm joined by Shamez Ladhani. Professor Ladhani is a pediatric infectious disease expert. He's in the United Kingdom, and he is based in London. Is it right? London?
Yes, yes.
You're you're based in London, and throughout this pandemic, you have been a commenter on these issues, of course, on social media, but you've also been primarily a researcher. And I know you most from a number of important publications, which I think we'll allude to and talk about. And for listeners who want to know what we're going to talk about, I think the things we're going to try to hit on are risks to children, long COVID in children, vaccination in children, whether or not we should take how we should incorporate natural immunity. We'll talk about face masking, and we'll talk about schools, and then maybe we'll talk about myocarditis insofar as it relates. Professor Ladhani, thank you so much for taking your time.
Well, thank you very much, Vinay. It's truly a pleasure talking to you because I've seen your podcasts and they're very entertaining. And that's what I like about this is actually taking the information out to the people who need to hear about it. So it's very different from academia. It's targeting a very different audience, but I think it's very, very important that whatever we do in the academic world, we bring it out to the people so that the information is available out there. So this is a great opportunity, and it really is a pleasure talking to you today.
Well, thank you so much for that. And I feel likewise. And I think you bring a very nuanced and important perspective. And your perspective is particularly important, I think, in the United Kingdom, but more so maybe in the United States, where I think we have leaned a different direction on some of these issues. We have a bit of schizophrenia. We have places in this country that basically never even acknowledged COVID-19. And we have other places that are doing extreme measures to this day on children. And maybe we could talk about that. But first, I think it might be great for you to talk a little bit about the many hats you wear, your clinical duties, your research duties, role you play in the vaccine program, so people can get a sense of the background you bring to this.
So I have a three-pronged job. I am a clinician. I am a pediatric infectious diseases specialist. I do ward rounds. I do clinics. I see patients with complex infections, children, and COVID is just one of them. So throughout the pandemic, we've continued our normal work. We have continued to support the hospitals and the wards. We have supported our colleagues when they've been unwell with COVID and provided the extra cover that's needed in the hospital. So being on the front line gives you a really good indicator of what's happening out in the real world, which you can then take back to public health and academia, where most of my other research takes place. So that, to me, is an important part of who I am, the clinical work that I do. But I'm also affiliated to a university where we do a lot of studies and clinical trials, and we've been doing a few for COVID as well. But more than half my job is working in public health. Before the COVID days, I was the clinical lead I still am the clinical lead for a number of vaccine preventable diseases, focusing mainly on children. My interests are in bacterial meningitis. So Haemophilus, pneumococcus, and meningococcus are where I've been doing this for more than a decade. And one of the things about public health is that there's very limited public health speciality for pediatrics, which puts me in a very unique position where I can provide the pediatric expertise in a public health environment, which I think has been extremely important during the current pandemic.
I think that is such a great perspective. I mean, you have expertise in, I think, all of the salient things that people think about when it comes to this pandemic. Let's talk about risk to kids first. And I guess I'll say something that I saw. Early in the pandemic, I saw a figure from the CDC, and it showed the risk of death comparing a child 8 years old to an 88-year-old. And, in biomedicine, I'm used to seeing tenfold differences in risk, even rarely hundredfold differences in risk. This was 8,700 times increased risk of death in an 88-year-old and an 8-year-old. And to me, the moment I saw that statistic, and the moment I also saw, I think, initial reports of the IFR in children, particularly, I think, the range of 5 to 11, where it is really sort of the nadir of the curve, obviously a little bit higher in very young kids. The moment I saw that, I thought to myself, this has got to be able to be leveraged into health policy. We have to be able to have a target this, take advantage of the fact that, kids, thank goodness, are not going to face the brunt of this illness like very old people will. I wonder how you conceptualize risk in kids, how it's shifted over the pandemic. I think now I saw the news, UK guidelines has actually dropped a little bit, the IFR in kids, how it compares to other things like flu and some of the other illnesses you think about. How do you think about kids, and do you think differently from 0 to 2 and 16 to 18 than the middle group?
So you bring in a very important perspective in the way you've put it, and it's a very adult-orientated view of the whole age spectrum. And from a pediatric point of view, I think very early on it became very, very clear. And the early Chinese studies, for example, showed a very low risk of infection, hospitalization, and death with children. But from the work that we do and with the people I work with, to us, it was very clear that it just doesn't make sense that children wouldn't get infected less than adults. And the idea that children don't get infected and they don't get sick and they don't pass it to others just did not follow biological plausibility. So even when the early Chinese studies were showing only less than 1% of children being tested positive across the spectrum of age groups and so on, to us, it just told us that this was behaving like many of the other respiratory viruses, and that it was likely that many of the children were either asymptomatic or had very mild transient infections at the time. So we were quite clear right from the beginning that despite what the data that were coming through, that children are probably getting infected. You can't be in a household and isolate yourself from your children. It's just not possible. When you have your own, you know that's not possible. And we realized that actually this virus may be getting to the children, but they're not getting sick with it. So I agree with you that the risk of serious illness and death in children, we already assumed was very, very low. What we were interested really is what their role was going to be in terms of transmission and propagating the pandemic over time. So what we did know is that it is most likely that adults were driving the infection early on because of the contacts that they had in terms of travel, work, and so on. But, as we got through that phase and the adults either got infected or if a vaccine came through, then it was all going to come down to children. So we had already assumed that the risk was going to be low in children. What we were interested in, what part are children going to play first in the pandemic and transmission and the protection to the most at risk, which is the elderly, building on our experience with influenza, which clearly it's not a similar disease as we find out, but also that, if once the adults are sorted, what's going to happen to children? How are they going to fit into this pandemic? What is going to be their role in infection and transmission? And most importantly, we realized how important schools were, not only for their well-being, but also as sources of infection. And one of the reasons we started investigating school transmission studies very early on was to try and get a handle of that. And we did that with antibody studies because there was no way we were going to capture it with swabbing and PCR tests, because the virus was asymptomatic in most children that we knew at the time. And we knew that just the PCR test was going to miss that component of it. But if you had antibody, not as a marker of immunity, but as a marker of prior infection, you can get a real handle on what is the risk of infection to children, what is the likelihood that they're going to be symptomatic, how are they going to transmit the virus to others, and what are we going to do to mitigate that in the future as the pandemic progresses.
Yeah, I think that's really well put. And I think many people who made initial, anchored incorrectly was they had a strong prior for influenza. And I think they anchored and believed that this virus would be a lot like influenza, which of course it's not a lot like influenza in many different ways. I wonder if you might talk for a second. I mean, I've seen seroprevalence, which is what you're talking about, the antibody screen. I've seen seroprevalence estimates in the UK in the age group of 5 to 11 as high as 70%. Is that a reflection of what the on-the-ground reality is right now? We're talking about 70% or 80% of kids have met the virus and cleared it.
So yes, so 2 steps back again. The antibody studies were really important right in the beginning, because what we could see very clearly is how it was different in adults compared to children. So the first thing we noticed was that when we went into schools back in June 2020, so within 3 or 4 months of the pandemic in the UK, the antibody positivity rate in the children was not that different from the staff in schools. That straight away told us that children were as likely to get infected as adults. And we could believe that perhaps children were less likely to transmit the virus to each other because they're smaller, they have smaller airways, they are not as symptomatic, they're less transient. You can imagine that the risk of transmission may be a little lower. But what we were able to tell straight away is that children do get infected. And even when they have asymptomatic infection, they mount a very robust immune response to that virus in terms of both antibodies and cellular immunity, which actually we subsequently showed is better persistent and gives you as good protection against variants as adults do, despite them being asymptomatic or mildly
That's
symptomatic.
an important point. Okay.
And it is very important because it does give us not only the fact that these children were getting infected, but actually their immune system was designed to identify new viruses and develop an immune response to these viruses, just like many other viruses, which is very different to the adults who, when they encountered a new virus, their immune system acted very violently and they ended up being very sick. So measuring antibodies was very, very useful. And in fact, the early studies that we did using antibodies showed us quite nicely that if you have mitigations in place in school, the basic mitigations, we never really had face masks, you could actually maintain very low infection rates in schools. And the only time you lose control of infection in schools is when the community infection rates are far above what you would be comfortable with. And what happens is you get multiple introductions of the virus into the school, and then that seeds. But if you keep the community infection rates low, you can keep schools open with very little transmission in the schools.
Let me ask you this question. I mean, I know people have shifted on this a little bit, but at the time, and even to this day, is transmission among a healthy child an undesirable outcome, or is it desirable?
You are there. The problem with answering that question, Vinay, is the risk perception for people is very, very different. So, a parent who's worried about a child or is surrounded by people who are vulnerable may feel very uncomfortable with the idea that the child is going to get infected and may transmit to others. From a public health point of view, we know that happens all the time with respiratory illnesses. There are very few respiratory illnesses where children aren't the main drivers of infections. They get infected. Sometimes they get very sick with it. Sometimes they transmit it to others, and other people do get very sick with it. That is the biology of respiratory viruses. In terms of whether that's a desirable effect or not, it depends on what the consequences are in children. So we look at death as an outcome, and I think we would all agree that death is the risk of a fatal outcome from COVID is extremely low. And yes, you can case count everyone and sensationalize every child that died. When you put it in context with other infections, other illnesses, and other non-communicable diseases, look at road traffic accidents, accidental drownings, and so on, it is a very, very tiny component of the childhood deaths that we see in the country. Hospitalizations also, we find very, very low rates. They are skewed towards those who have underlying comorbidities. And also what we do find, and what is really hard to get handle on, is that if you have a lot of community infections, you're going to have a lot more incidental infections in the children who are presenting to hospital. So hospitalizations per se, as a severity marker of severity, it's not a good indicator for children like they do in adults, because most of the adults go in, they're very sick. While in children, they are mostly asymptomatic. And the only reason we're picking them up is we screen every child that enters our healthcare settings.
So I think that's a key thing, which is that, in a setting where everyone on entry to hospital is screened with a swab in the United States and in your country, it is not a reliable indicator in the setting of a variant like Omicron, where, many of the people are coming in with the broken arm or, needing appendectomy, and then they happen to have it test positive. It's not why they were there.
So in our hospital, in the last year, more than 50% of the children had asymptomatic infection. They came in with something that was completely unrelated to the virus at all. And if you look at those who came in with acute COVID per se, it was about 15%. So only 1 in 6, 1 in 7 children actually had acute COVID. And even those, they got better. They need a bit of help, they need a bit of oxygen, a bit of treatment, and they go home. So that is not, to me, a marker of severe disease. It is significant and it is disruptive, but you get that with rotavirus, for example, and other mild illnesses. It happens because you will have a tail end of severe illnesses. So then the big question comes really about long COVID. And that is the big issue, is that once you can't look at death as an outcome and you can't look at hospitalization as an outcome, you're only left with long COVID to justify why a child might not get, why it might not be desirable for a child to have COVID. And that, again, is the extrapolation of adult data to children, I think, has been very, very damaging in terms of propagating fear about the unknown, because you are using a very vague and abstract construct of an illness that has no definition and no boundaries. And I think that is probably one of our biggest failures in the pandemic.
Yes, I think I wholeheartedly agree there, and we'll come back to that. But maybe just to hit on one point. Right now in the United States, there's someone who might listen to this who has got kids between the ages of, 2, 4, 6, 8. And let's say hypothetically this person, the kid is unvaccinated. In this country, though, of course, for 5 years old and up, they may already be vaccinated. But I saw somebody tweet something. They said, I have a 4-year-old who's not eligible for vaccine in this country. The parent is healthy, fully vaccinated, maybe 3 shots. The other parent, 3 shots. The grandparents, 3 shots. And maybe they live in a different city. Who knows? But they're saying, I am preventing my 4-year-old from playing with other children for this entire pandemic because I'm worried about my healthy 4-year-old. And if this 4-year-old gets sick, I'm worried that for their own health. I guess I feel like I want to reassure this person and say, there are pros and cons to letting your 4-year-old play or depriving them of play for 2 years. One pro is that you may have marginally reduced their risk of getting this virus. Maybe not, but depending on what else you've done, but maybe you've marginally reduced it. But the con is that this child, half their life, they've not been able to play with peers. And that to me is tragic. And so I wonder, how would you counsel such a person who's anguishing about this decision?
Vinay, it goes past that.
Yeah.
It's the social isolation.
Yeah.
Yeah. And that has mental pressures. And then you end up going to social media, which has its own consequences. I can tell you that after the first couple of lockdowns in the UK, our pediatric wards over here were filled with children with mental health problems, not COVID, not related to COVID. These are children who have tried to commit suicide, from children as young as 10 in our intensive care units, who should not even know what suicide means or attempted suicide, who are in such bad places that they are self-harming themselves. We have seen eating disorders, both in terms of overeating and obesity, but also in terms of anorexia, to the point that they require hospitalizations. They have no boundaries. They have no peers that they can compare themselves to. They have nobody to interact with or actually find a balance as to what is appropriate and what is not appropriate. And they're setting their own boundaries without any social support. And I think rather than the concerns about them not meeting their peers and being educationally delayed and socially delayed, the harms that we have done by isolating children from each other is going to remain with them for many, many years to come. And I think that is the damage that we've done. So to answer your question, yes, by doing what is being done, there is a lot of damage happening. The question is, what is the risk to that child of getting severe disease? It is extremely tiny. The risk of the infection fatality rates are ridiculously low. Hospitalization for COVID is probably in the region of about 1 in 150, 1 in 200 infections, so good going infections. So even that is a tiny risk. And we know that this idea of long COVID, again, coming to it, is that I think it is completely misinterpreted by people to think that it is a lifelong debilitating condition, when actually all it means is that there's just a few more children who take a bit longer to get better from their illness as anyone else. It just takes longer. So even when you look at long COVID, the symptoms do get better over time. It just takes a bit longer than everybody else.
Okay, let's talk about long COVID. So I guess what I think about long COVID that's unique is that this is a disease entity that, initially gained a lot of prominence from media coverage and from social media groups where people were sharing their experience. And only later became sort of a scientific phenomenon and now has enough grant funding behind it that it will launch many careers. And I am confident that there is real long COVID, i.e., that when you are very sick with any debilitating illness and you're in the ICU and on a ventilator, it's going to be a long convalescence, and some of that may be with you forever. For instance, neuropathy or something like that. I'm confident that when you're very, very sick, it's possible that it takes a long time to mend all the way as an adult. And you can speak more about kids. I'm also confident that as a general rule, kids are much more resilient than adults in all sorts of things, from chemotherapy dose to everything. They're much more resilient in that way, and not from social deprivation, perhaps. And I'm also confident there's lots of things that happen after illness that may or may not be attributable to the illness itself. It might be attributable to the fact that, you've had a tough time in your life, or that other things, our society is very dysfunctional, not the way it normally is. I think the long COVID studies they have a lot of difficulty in teasing these things apart. And I also think that the more they are publicized and talked about, the more doctors will look with more scans. And the more you scan someone, the old saying that show me a healthy person, I'll show you someone who hasn't had enough scans, because you'll find something. And so I think, long COVID is, as you say, it has no bounds on the definition. It can be anything you want. And just because something happens after the fact doesn't mean it was due to the fact. But when we extrapolate to kids, you have put together some nice research, threads, papers, where you have really sought to quantify frequency of long COVID. And I think you're really good to point out that we're not talking about lifelong debilitation. We're talking about it may take you a few more months to mend. I wonder if you might talk about some of the precise estimates that you have found.
So it really depends. Again, you are asking me to talk about a disease that has no definitions. And I think it's very hard to define because everybody has their own opinion about what it should be. And the way it stands right now, Vinay, is really scary because the definition by itself says you can have symptoms of COVID or no symptoms of COVID and be completely asymptomatic. You can test yourself, or you don't have to test yourself.
Right.
Or you can have symptoms when you become unwell, or after you become unwell, or even 3 months after you're unwell. Mm-hmm. And your antibodies may be positive, but they may also be negative because your immune system is messed up because you might have long COVID. Your symptoms can get better and then worse again. You can get new symptoms that is completely unrelated to your original infection, or you could have symptoms that were there right before the illnesses that just got worse after your illness. And all of that is long COVID. And therefore,
it violates a principle of science, which is called falsifiability. What isn't long COVID by that definition?
And that is why the early studies reported over 200 symptoms for long COVID. And I don't know of any medical condition that has 200 different symptoms for one viral illness. And that's why it's very difficult to tease out what is real and what is not. Mm-hmm. And no matter how well we've done all our studies, mm-hmm. I assure you that none of these studies are of a standard that is acceptable because they all have their faults. And the biggest fault is that the same symptoms are present in those who are cases compared to those who are controls. And therefore, you don't know what contribution each one is having. The reason I say that is that every study that we've seen so far, essentially, the person that you're asking the question to knows their status. And so what happens is if you know you have COVID and then you get a headache a month later, you will end up attributing that headache to the COVID. I had COVID last week. I now feel like this because of that. Yeah. Every time I smell something unusual, I think, I had COVID 3 months ago. Is this a remnant of my loss of smell from that time, even though it got better within 2 or 3 weeks? And if you don't have COVID, it goes the other way. You say, well, it can't be COVID. It has nothing to do with COVID, even if I have a headache.
I think, that's a huge problem with a number of studies. This is that the knowledge that you had the disease will affect your recall of symptoms in the short term. I also think it's a problem with, we can come to this later, but it's a problem with mask studies too. Because if I just told you got COVID, hey, by the way, did you wear your mask properly? And now suddenly maybe I did, maybe I didn't. After all, I got COVID, maybe I didn't wear it properly. And now you can do a study that says people who didn't wear their mask properly are more likely to get COVID. Because you just told me I had COVID and now I got a little scared. And if you told me I don't have COVID, then maybe I wore it properly. So of course, knowledge of what happened in this world of understanding will affect, I think, your perception of what you're feeling. Yeah.
And more importantly, Vinay, people who wear masks are not the same as people who don't wear masks.
Of course.
So they don't just wear masks. They come in a package deal. And therefore, their risk behavior and their testing behavior are completely different to those who don't. And therefore, ecological studies will never be able to answer these questions. So you can try. So coming back to long COVID, you can try and mask this by hiding the questions. So you're asking the same questions to the cases and controls without making it an issue about whether they had COVID or not.
Or you enroll seropositive patients who don't know they had it.
That's very difficult to do, especially in this age and time, because so many have already had COVID. And if you use PCR tests,
use antibody and then exclude anyone who says, I think I had COVID, and just take the antibody positive ones who say, I don't think I had COVID, but then you'll get the people who are less sick.
There are some brilliant studies. There's one in the JAMA network, for example, that looked at people who had COVID, people who think they had COVID, and people who didn't have COVID.
JAMA IM paper, yes.
One. And the one that was associated most with was those who think they had COVID.
Right.
But again, the argument is that people with COVID don't develop normal antibody responses, and therefore you are failing to test them properly. So it's a very difficult battle to win, because whatever tests you do, you use PCR tests and say, well, they were negative, because by the time you tested them, the symptoms had gone and the virus had disappeared. So it's not that, it's just that people like us who are on the front line, who are looking after children all the time, are not seeing the level of long COVID that is being described by social media and the news, for example. And what is happening is, like you say, there are some kids who have post-COVID syndromes. So loss of smell and taste is very prominent, and it takes weeks to months to get better, even in children. Okay? And you can call it long COVID if you want to, and it's really debilitating. It's socially debilitating because you can't taste or smell anything. It makes your life miserable, but you get on with your life.
My understanding is that that is something that is very highly unique to this virus, which is the olfactory bulb involvement. It's why in many of the original studies, one of the things that is the best specificity that you in fact had COVID is loss of taste or smell preceding your illness, right?
Yes. But then what you see in children, the post-hospitalization syndrome that you described, where you get an organ damage, which takes a long time to heal, it happens in children, but it's not that common. And like any other viruses, you do get chronic fatigue syndrome with children. And SARS-CoV-2 is no different. There are children who will get chronic fatigue syndrome with this virus as like any other viruses. That's also classified into long COVID. It's the other group that I think we are failing to define and support, where the symptoms are non-specific, they are more neurocognitive, where it can actually affect the daily living, but we can't find them because they are hidden in all this dilution of symptoms that are being attributed to a condition. You know, the fatigues and the tiredness and being able to sleeping too much or not sleeping too much, or headaches. These are symptoms that are common to both cases and controls, and it's very difficult to say this is due to the virus. There are many reasons why it may be. But then by doing this, what happens is the very few kids that are really, really unwell, who need support, medical support, psychological support, social support, are difficult to identify because we don't know who they are or where they are. And I think that is a failure of the system again. And I think if we don't if we don't define the condition and support these children, I think they're going to have a really difficult few years ahead of them.
That's really well put. Two things are true. It's rare, it's uncommon, but for the ones that are affected, whether it was due to the COVID or not, they may benefit from the social supports, whether it's due to the COVID or the fact that their life was turned upside down. Let me ask you this. Vaccinating kids. Right now there's a bill in California that will throw them out of school. If you're 5 and up and you don't get 2 doses by January 2023, you'll get thrown out of school. And this is a place that has already thrown everyone out of school for 18 months in lots of places, more than a year. There's no exemption if you just had Omicron. In fact, you could have Omicron and they'll make that, you'll have to get 2 doses within 21 days if you get, if you're close to the cutoff. I guess I want to know how you think about vaccinating healthy kids, and we can set aside kids who have underlying comorbidities. I think that's a separate issue. Healthy kids that have had Omicron, and then as a mandate to go to in-person school, which I think are 3 levels of turning up the temperature. Yeah.
So it's it's fine. We can talk about that, but I think also the UK perspective is very
Yes.
different because um, I think one of the things about the UK, and I don't make the decisions, and I have not been involved with educational decisions. That has nothing to do with me. That is the government working with the Department of Education. But starting from June 2020, we showed that if you have mitigations in place, schools are very safe environments, especially if community infections are low at the time. And in September 2020, the UK opened up all schools to in-person teaching, and everybody attended at the same time with mitigations in place. And we were still able to show that if you have reasonable mitigations in place and you keep community infection rates under control, you can keep schools open with basic mitigations, no masking. And so the idea was that you allow children to go to school and have a normal life. And we know that some kids will get infected, be it in school or outside school.
Right.
But the risk to the children was always going to be low.
Right.
There were concerns initially about teachers and the teaching staff getting infected in schools or through pupils or whatever the transmission system was. There was worry that the children could potentially transmit the virus to the teachers. But once the vaccine program came in December 2020, that became less of an issue because the argument was that you vaccinate the adults, including the teaching staff and the household members, and you allow the children to go to school and be normal. And so over the months, we took less and less precautions in school and allowed them to have a normal schooling over the end of last academic year, to the point that this academic year, from September 2021, the children were allowed to go to school without any mitigations whatsoever. The basis of that was every household member should be vaccinated, every teaching staff and non-teaching staff in school should be vaccinated, and there were boosters if they needed it at the time when the time comes right. And so children would go to school. Now, what was unique, as you know, with the UK is that the UK JCVI made a decision for 12 to 15-year-olds that the benefit risks of vaccinating healthy 12 to 15-year-olds were very marginal. And that means the effort, the money, the vaccines, the resources, the healthcare time, the staffing, everything that you put in to implement a vaccine program for teenagers does not justify the outcomes of the benefits of vaccination,
Right.
because you are taking that away from other important healthcare resources that may be needed at the time. On top of that, there were concerns about myocarditis, as you're aware of. And be it the risk being very small, the concern was that there is no such thing as mild myocarditis. Inflammation of your heart muscle has to be taken seriously. Even if you end up in hospital for a couple of days and come out of it, that's not the end of inflammation, because we know inflammation can lead to scarring and permanent damage. And the heart is the only organ that's going to keep you alive the longest. And any damage done to the heart has to be taken seriously, especially if you're balancing it with a condition that is in itself very low risk to healthy children.
Right.
So that was the argument at the time. So when you talk about mandating, the UK started in a completely different place, where we said, well, maybe we can use those resources in a better way to, improve routine vaccination, which we knew took a hit, or providing extra services for children with mental health, or whatever else is needed.
But now I just touch on the 5 to 11 JCVI decision. Same.
Yes. So it goes through processes. So as you know, that the JCVI decision was overturned, and
by the politicians,
by the UK, the ministers who said that they're going to vaccinate children to prevent educational disruption. And at that time, credit to them, if these vaccines prevented infection and transmission, then it could potentially have reduced education disruption. I mean, it could have worked.
Yes.
We know better now.
Right.
But the process was you do 12 to 15-year-olds, and then you do high risk 5 to 11-year-olds, and then you consider the healthy 5 to 11-year-olds. And that process has continued. You can't sort of jump the queue and make decisions too quickly.
I see.
we need to vaccinate those with comorbidities first. And while they're doing that, the deliberation continues about as to whether to vaccinate 5 to 11-year-olds. But you can imagine I don't know what the decision is going to be, but you can imagine that whatever the decisions were for 12 to 15-year-olds, they're going to be even more marginal for the younger ones. And therefore, the justification to vaccinate even younger children becomes more difficult, even though I don't know what their decision is going to be whenever they make it. But I hear it's imminent.
I see. I guess, I mean, I honestly don't know. Let's just say you're taking a 5 to 11-year-old, and let's say you have one that's healthy, and this person had Omicron. Okay, there's lots of such children in this country. I don't know how anyone is making this decision based on science. I mean, what is the decision based on? What is the probability a healthy 5-year-old who just had Omicron will get sick again? We have the probability that an adult who had Delta or Alpha or, any prior variant, their probability of being hospitalized from reinfection of COVID is as low as it goes. It's bottomed out in CDC data. That's an adult who has a higher risk, Natural immunity is good in an adult. Now you're taking some kid who had 1 in 10 to the power of 6 or 10 to the power of 7 odds of bad outcome, who already had and recovered from the disease. I think it's 100% speculatory. Nobody even knows what vaccine will do.
So it comes back to why you're vaccinating.
Yeah.
And I think the messaging is lost in there.
Yeah.
Okay, so for example, the UK was vaccinating to prevent education disruption by preventing infection and transmission.
Sure.
If that is no longer the case, because the protection against infection with the vaccines is very low.
Yes.
Because it wanes very quickly, especially with Omicron.
Yes.
The protection against transmission, therefore, is also low because you can transmit even if you're triple vaccinated. We know that now, right?
Yes.
What we're also finding is that many of our teenagers who were infected with Delta last summer are the same kids who are being reinfected with Omicron. They're getting very limited. And we're already seeing these reinfections in the teenagers. So we are 2 steps ahead of you in that we have children who have had Delta in the last year.
Yeah.
And then they've got Omicron in this last wave.
Right.
And coming back to your question right from the beginning, as of 2 weeks ago, more than 90% of the teenagers have antibodies against the virus.
Wow.
We've already hit 70% in the middle of January with primary school kids. And we were only halfway through the wave at the time. So you'd expect that number to be much higher. So we've already got all that infection that has already taken place. And now the question is, we want to vaccinate them. And at the end of the day, there is very clear evidence that vaccination will reduce your personal risk of severe disease. And if that risk is very tiny, if it's 1%, it will reduce it by, 50, 80, 90%, depending on how far you're from. There is that tiny risk that will be mitigated. But if you're looking at a population that is already highly immune, for example, the added benefit of vaccination gets even lower. So coming back to your question, I agree with you that if you've had natural infection, the benefit of vaccinating becomes very limited. And the other problem is we know very clearly that the benefits of vaccination are time limited, right?
Yeah.
So you get a few weeks, maybe a few months before that wanes. And so if you are mandating vaccine now, then to maintain the rationale for vaccinating, you have to keep vaccinating them to get that benefit over time, which is where we're stuck. Because where do you stop? 3 doses, 4 doses, 5 doses? And I don't think anybody knows the answer.
Yeah. I mean, I think that's all well said. I guess, in my mind that, obviously there's 3 buckets of things we're talking about. We're talking about protection from a mild infection and transmission. We're talking about protection from hospitalization, protection from death. And I think it is clear. I mean, I think it's hard to argue that for somebody who has never met SARS-CoV-2, an adult, that being vaccinated initially will do maybe log-fold reduction to risk of death. Amazing benefit on your risk of death, which will be very good for you going forward. Hospitalization, I think, is still reduction. now the symptomatic infection part, I think the vaccine effectiveness is plummeting. I mean, I'd be, if it's over 30% 3 months out, I'll be impressed. But I think it's plummeting, which is rather modest. Which means that in the long run, it's not going to halt transmission, and you're still going to get breakthrough infection. That's inevitable. But I think the one thing I want to add is, like, in somebody who has had an Omicron or Delta, I just don't think we know that being injected with the mRNA from the original ancestral strain does any good to you. I mean, yes, you could argue that it will have a short-term reduction in a symptomatic breakthrough from potentially getting whatever the next variant is, maybe. I mean, that's speculatory. But your hospitalization risk and death risk are already bottomed out, and I don't know if they can be further lowered by getting an old construct. Thoughts?
And it is true. Every study that I've seen shows that reinfections are associated with milder infection in adults. And even in kids, we don't see any evidence of reinfections being a problem, even in the kids, the small proportion who do get it. So I agree with you from a simple biological perspective. If it hits you the first time and you don't do badly, the second time you've already created barriers to stop that happening. So
Right.
it can't possibly be worse.
Right.
Again, if you have underlying comorbidities, it's a different ballgame completely. But a healthy child who has seen the virus, even if he sees a variant of that virus, will have some defenses in place. And therefore, the second infection should rarely be more severe than the first one. And so I agree with you. And therefore, the added value of vaccination becomes limited. I can tell you from the immunological studies that we have done,
Right.
And that was mostly with the Alpha or the Delta variant infections. Right. Giving one dose of the vaccine does boost your immunity. It's like getting a second dose. It improves your antibody response for whatever they're worth, but we can also see improvements in cellular immunity in the children who've been infected and they get one dose. But what we also see very clearly is that the second dose does not add very much at all. So then it just takes us to that point, and you, Vinay, have made this many times, is that we need better data to use this smartly.
Yes.
Should we be thinking about the extended schedules, as you already know? Should we be thinking about lower doses? Should we be thinking about different vaccine platforms? And we need a little bit more time to get that right, rather than jumping in and doing things very quickly just because there is only plan A. And I think that's where we're stuck with at the moment, is that nobody wants to look at alternatives.
Right. No, and I think, the point I always try to make is that, Pfizer has made tens of billions of dollars, and it's not the role of Pfizer to run all these studies. It's the regulator to compel them. And in this country, we could do so many simple studies. 1,000 people with documented natural immunity get randomized to 3-arm study, a 1 dose, 2 doses, or no additional doses, and follow them for hospitalization, follow them for other, it could even be bigger sample size, 10,000 people. There's so many questions that come out of this, I think, very quickly, that can be answered with a series of studies that the manufacturer should be compelled to do. But they're not doing them fast, including their myocarditis post-vaccinating kids, not their troponin study. They're supposed to draw random troponins, and that's ongoing.
So Vinay, in that way, I have to say that UK can be proud of what it's done.
Yes.
Despite going against marketing authorization for vaccines as soon as they were licensed. You may not be aware that we recommended the vaccine for 12-plus-year-olds with severe neurodisability as soon as the vaccine became licensed for adults.
I see.
Despite there being no clinical trials in teenagers at the time, the risks that they were suffering, the risks that they were put with COVID, justified vaccinating them with the vaccine that hadn't been authorized for that age group. Because it made sense to give it to them while it was available, because their risk was so high.
Right.
But
I think along those lines, you could have argued, actually, and I think maybe towards October of 2020, we could have started to vaccinate nursing homes, or we could have just done a mega randomized trial, which is that, after you accrued 40,000 people, just keep accruing, like some UK study designs. You just keep randomizing people until you get the signal. By then you'll be ahead of the curve. But I think you're right. Yeah, there are some high risk populations. It makes sense to.
But what I was also going to say was that the government has commissioned a lot of studies to try and answer these questions, which pharmaceutical companies wouldn't. For example, mixing and matching the different doses.
Yes, yes.
We have studies with 7 or 8 arms looking at different boosters that you could give and how they performed against each other.
Yes.
And within that, we're already doing studies in the younger ones, and we're using lower doses and mixing and matching doses in the younger ones, the teenagers and so on. And we're already ahead of the curve with that. But it takes time to get there. And we are already thinking about lower doses for children, using another vaccine for children, thinking about other platforms that might benefit children that aren't as reactogenic, for example, or
Right.
aren't as immune heavy as the mRNA vaccines. The antibody levels that the mRNA vaccines make are phenomenally high. It just makes you wonder how much of the immune system it utilizes to respond to those vaccines. And there may be other vaccines that may be better suited for children that might be safer and achieve the same outcomes that we want without being concerned about just having to boost them all the time. So the UK is already doing those studies, and we should have results within weeks as to how best we can tweak the program to try and get maximum benefit with minimal harm.
And I think that's the key, which is that's what I think people forget. The goal of this is maximal benefit with minimal harm. And I think we forget the second part. I mean, in this country, this is what the policy is right now. Anyone 12 and up, no matter if you've had Omicron last week, recommended to get booster. And a lot of places by brute force will do it. They'll be thrown out of public school. They'll be thrown out of after school activity. They'll be thrown out of college. So we're talking about like a 20-year-old man who had 2 doses of Moderna, 200 micrograms of Moderna, and now they have a gun to their head to get either a 30 of Pfizer or 50 of Moderna, or they're going to be thrown out of college. That to me doesn't make a lot of sense. I just think that, they probably don't need any booster at all. And if they are going to get, and they certainly don't need to be compelled by brute force to get it, that's where we are. And it's so different. Go on.
But coming back to you, the brute force bit it's the imposition that, again, I think the UK has done really well is we have not. Our mandating of vaccine has been extremely limited. I think we stopped at social workers in care homes. We tried healthcare workers, but that didn't go through because we realized that the reason for mandating healthcare workers to vaccinate is to protect them getting infected and transmitting to
the
others.
patients.
That was no longer valid. So that has been backtracked and that is on hold at the moment. But apart from that, we have never really mandated vaccination. We don't do vaccine passports. You don't need to show your vaccine status when you go into indoor areas and so on. And I think we've done really well. But, the idea that you're forcing people to vaccinate their children when they are not sure that they want to, I think does more harm than good because it destroys trust in vaccines and in the people making decisions about the vaccine. And I think that has consequences for the whole of the immunization program, not just for this. And the reason I say that is if you look at the US, for example, you are really struggling to get over 50% uptake in your teenagers. We have a program that's in place, and guess where we're at? 50%. Look at other countries. Many of them are still stuck at 50%. It just looks like parents are very divided on this. Half of them do and half of them don't. And they should be allowed to. And if one of the reasons why they don't is because the child's already been infected and they know that the child is safe because they have immunity, then they shouldn't be forced to be vaccinated at all. I mean, mitigations is another level because why are you vaccinating and then putting them through mitigations? Which raises its own issues because the whole point of vaccinating is to take off mitigation so you can have a normal life. So there's no reward for it. You just that stick that you can't socialize, you can't go to indoor areas, you can't go to restaurants. You can't travel. And I think it's disproportionate in terms of what we are making children do and what they gain from it.
Yes, I couldn't agree more. I mean, I think just to say a few things about our country, why I get so irritated. I mean, my understanding is your country, you're talking about people over the age of 65 who have not had one dose. It's like single-digit percentages, if that. This country, it's double-digit percentages, over 65 without one dose. That's a huge error in a vaccine program for this virus. Are you crazy? That's untenable. Meanwhile, we are putting so much pressure on the populations that don't need to do it. I have lamented that, I was compulsorily boosted, at the end, under penalty of termination at the end of last month. Do I believe I feel violated in many ways, but one is that I know for sure I didn't benefit from that stupid booster. And also I do question the intellectual fortitude of the people making the decision making, and that undermines my trust in a lot of things. And I think in this country, what will happen is, the vaccine mandates. Los Angeles was going to do it for 12-year-old boys, 2 doses, or you're going to get thrown out of school. I wrote that was not going to end well, and then just at the 11th hour, as they're about to do it, they look and they're going to have to throw out 30,000 children, mostly poor and disproportionately minority, because there's different uptakes based on racial groups. And so, for those of us on the progressive left, of which I'll put myself, for many years, we were rightfully concerned about policies that inadvertently worsen socioeconomic and racial disparities, and how that can be a blind spot in policymaking. Simultaneously, the most liberal city in this country is about to do a policy that is exactly the racial discrimination that they lament. And the hypocrisy was crazy. And for what goal? To protect these kids from a virus that is not their greatest concern. Talking about children who are victims of, they don't have enough food to eat. They're victims of gun violence. They're victims of, so many tragedies in life. And you're taking away, and the punishment is they don't get to go to in-person school, the one good thing that was going for them in their life. I found it to be bizarre and cruel. But this is where we are in this country.
And in the UK, it's also, if we just did our first tranche of looking at the children who got vaccinated, and among the rich and affluent populations, is up to 75%.
Right.
And in the lower end, it's 11%.
Right.
Yeah, the very children that you want to be protected are the ones who are not taking up the vaccine. And, one of the reasons is their distrust in the system. And by mandating, we're propagating that fear, that distrust. And this is COVID. And to be honest, I'm less interested in COVID, but they don't take their meningococcal vaccines and they don't take their other vaccines. We're going to end up in a really bad place in a few years if we can't keep up with our routine immunizations, which we know is highly beneficial. And a lot of them need population level protection, because it's not, you have to reach a certain level to protect those around you. And we know that works. And we are putting those at risk for a vaccine that gives marginal benefit, personal benefit to children. That is very difficult to quantify.
That's well put. We have in this country, in Georgia, there's legislation to remove MMR vaccination. So we're going to have, I don't know which state will do it first, but somebody will do it in this country. And it's a backlash to this heavy-handedness, and it will result in catastrophic outcomes when they get hit with a huge outbreak. And it's so I think that's an important point too, that loss of trust in vaccines may bleed over to the vaccines that really matter, and may bleed over in other ways. Spillover effects in biomedicine and history are very difficult to tell. There can be spillover effects on taking your child to the doctor at all, allowing a doctor to examine the child in any way, shape, or form may have some spillover, and that can lead to all the bad things that happen from getting kids that lose touch with healthcare systems. But let's talk about some other things I want to talk about with you. Masking, because I think that's a good topic. And then myocarditis. But masking, what are my thoughts on masking? This is such a strange country, because we are simultaneously, there are parts of this country that are so unwilling to do anything to mitigate the virus effect. But there are other parts of the country that are so willing to do the most visible thing. And masking, I think, quickly took on a visibility. And it was, I remember March 2020 when Tony Fauci went on 60 Minutes and said, we don't recommend community masking for adults because the evidence base was weak. And I read some of the many papers by McIntyre and others and the randomized data, and I noticed that it is not so strong. But then within a month, I think people felt like out of the precautionary principle, it's reasonable to do it. And I actually didn't disagree that much. I do think it's reasonable in times of crisis to do things you've never done before. But I would have liked to, while you do something, implement some cluster, stepped wedge, some design that will get you some better clarity. But we never did that second part. And in fact, I suspect that it was actually sabotaged, because that people who were propagandists for the intervention were so vehement that they actually prevented other people from having more sort of uncertainty to ask the question. And, we're going to end this pandemic with Denmark, Bangladesh, and maybe there's Bangladesh part 2 coming, and then maybe Guinea-Bissau. But we won't have, I think, evidence that's really particularly relevant to London or New York City or San Francisco. No evidence in children, no evidence in populations with natural immunity, and no evidence in populations with vaccination. Okay, that's one thing. The next thing is the age we start. This country in California, if you're a 2-year-old on an airplane, they'll throw you off. I've seen, if the family doesn't put the mask on the kid, they'll throw them off the airplane. They'll be banned from travel. And in daycares, it's often mandatory. In California, it's mandatory indoors and outdoors in a lot of school districts. There's no evidence. I don't know what to say. It's just no evidence. I don't know. What are your thoughts?
So funny. I think we're very alike in where we started. The evidence for face masking outside the healthcare setting was limited to none.
Yeah.
And the idea that you can wear a mask, because when you wear a mask, it has to be fitted, it has to be tight. You can't touch it. You can't play with it. You can't keep moving it around. And when you're done, you put it in the bin and not in your back pocket.
Right.
There are so many things that wouldn't be done properly out in the population that you do want, or even if you do recommend, you just end up people touching the mask and touching everything else. And there's a potential to make things worse rather than better at the beginning. But you thought, you're right. It's a precautionary principle. And I remember I was the one who used to say rubbish. And then after I said, well, maybe, we are in a bad place. If it helps even 1%, you do it.
Right.
And what concerns me is that 2 years on, 2 years, we have multi-billion-dollar vaccines that have been developed and used by them. We can't come up with one clinical trial that we can believe does or doesn't protect. It's beyond me. Yeah. It's completely beyond me. And I agree. There are invisible forces that don't seem to want to make it happen, because I can't believe any other intervention that has received less attention than this one. And, in a way, when you look at the UK, for example, the nice thing was that I think the government and the educationalists, or in between them, they appreciated that the harms of masking are likely to exceed any potential benefits. And we can do other mitigations which are less disruptive, but let's not mask the kids. So we never masked our primary school kids. And secondary school kids, it was a bit wishy-washy. It was like when you're in the corridors in the school, you wear a mask. But if you're in your classroom or outside, you don't have to wear a mask. So, how much that helped or what that actually did, we have no idea. But it was never enforced to the point that many other countries did. So we've been very, very lucky. And we don't see anybody under 12, we don't see masking at all. And I was in the States during the summer last year, and it's a personal thing, and I have, I admitted this is just me. I found it heartbreaking to see little children walking around with masks. It just did not feel normal, because we're just not used to seeing that. And it wasn't like the kids were doing very well with the mask, because most of them were wearing close masks, and half the time it was on their face. The other half, they were rubbing their faces on their mothers. And then they're coming and giving you a hug, and then they're putting their hands to pick them up. It wasn't like there was any infection control associated with the masking. But it's just very, very different culturally, because even now, 2 years on, we are not used to seeing little children in masks.
In this country, in San Francisco, you walk by the park and it's 100% outdoor mask usage. You have people playing soccer games outside with masks, playing basketball games inside. It's a lunacy. I don't know. I really think they've lost their minds. We're talking about very young children, outdoors, cloth mask. The mask is the one that didn't work in Bangladesh. We're outdoors. By the way, vaccine uptake is brisk in this city. Probably half these kids have been vaccinated anyway. Many of them have already had COVID. What is the goal of this intervention? And maybe I'm biased, because when I moved into my office, I was on the 4th floor and I had a big box of books, and you have to wear the mask and carry them up the stairs. elevator was out. And so I put the mask on and I huffed and puffed. And I was like, I'm 100% sure masks don't affect gas exchange. Like, I'm breathing comfortably, but the subjective feeling of dyspnea is real. And that's why you don't go to somebody with heart failure and put a mask on their face. Or, pregnant women in this country had to wear masks when delivering babies.
And imagine an N95 mask,
Oh,
8 hours a day. It's just, I agree with you. If there was evidence, you'd understand.
yeah.
And the UK Health Security Agency just did an evidence review recently to try and decide whether we should be masking.
Yeah.
And really, we can't find it. The only studies are ecological studies where, you use masks in places where there is a lot of infection and then the infection goes down. But you do 20 million other things when you're wearing a mask. Right. And therefore, you will see a reduction in infection. But there isn't a single study I'm aware of. And I'm happy to be proven wrong. I have no problems with that. I cannot find a single study that justifies mask wearing in schools. The argument that the mask is used is, even if it is a tiny fraction of a benefit of 1%, it accumulates over time. But you would think that after 2 years, you would have some indication. You have tweeted a couple of graphs. I think one of them was from the Spanish group.
Yes, that's a nice one.
You can do the same one in the UK a couple of times where we did introduce masks and take them off. And you can't tell. You can't tell that this is the point. And the mask was the only thing that came in and went out.
Right.
And you can't tell when the mask came in. And so you sort of do wonder that even if there was a benefit, it's likely to be so marginal that it doesn't justify the harms that it might cause. Well, and I think that's where we're at.
Yeah. And I agree with that 100%. And then, but one of the things people say is that, and this really gets a little irritated with, they say, there's never been a randomized trial showing it's harmful. And I was like, well, there's no randomized trial that says if you take a newborn baby and lock him in a dark room and never let him see the sun, that's harmful. You don't do studies to prove that depriving human beings of visual and auditory stimulation are detrimental. That's the default of nature. You need to prove your imposition has some value that outweighs the downside. Why do we even evolve faces? Why does my face move like this so you can see how expressive I am when I talk? It's for a reason, presumably. I don't know. Okay, that's one thing. Yeah, go on.
You bring out a really important point, is that we introduced interventions without evidence, which we would never have done in any other circumstance. And now the onus has been to prove that the interventions don't work, when actually it should be that we need the evidence to implement it in the first place. And if you don't have the evidence, it should never have got in. And I think that's where we're stuck at. It's like saying, let's give everybody a vaccine. If it doesn't work, we'll stop.
Yeah.
Do you know? And we wouldn't do that. We are in a really, really bad place with a lot of
things. Well, you wouldn't do that, but actually, there've been calls to just give it to the 4-year-olds off label. There are such calls in this country. That's how bad it's gotten. No, I think that's. But last thing to say, the American Academy of Pediatrics, they're the group that's supposed to be defending children, and they have been not good on this issue because, they have there was a lot of anxiety among parents who have been dropping their kids off at daycare. And it's possible that you could be a nurse or, some person who's working through this whole pandemic, and your baby has been dropped off in a daycare where for 10 hours a day, the baby doesn't see anyone's face. And I think understandably, a lot of people would be kind of concerned that that's not ideal. My understanding is in your country that actually you don't make the caretaker, people who do daycares for babies, infants, they don't have to wear the mask. That's what Alistair told me, Monroe. But the American Academy of Pediatrics tweeted out, do babies need to see faces? Well, there's no evidence that says they need to see faces, and kids will pick up with their ears. Their hearing will get sharper. Like my feet will work better if you cut off my hands. I don't know. Like, what are you talking about?
No, it is true. So one of the things is that we have never in the younger ones, we've never dissuaded staff to wear masks. I think most of the countries is the point where if you want to wear a mask, that's okay.
I see.
And if you don't want to wear, that's also okay. And those who are very strong believers of masking will not stop wearing it, and vice versa. In educational settings, again, it was the pressure was really mostly on the children either to wear it or not to wear it, but the staff were always given the opportunity to wear it if they wanted to. And that has continued, and nobody has any objections to them wearing it. And if they want to wear it, it's completely fine.
But they're not compelled to wear it. That's another point.
They're not compelled to wear it. No, they're not. And there's no mandate. As far as I'm aware, they don't have to wear it if they don't want to. And again, I think that if you look at the ones who are directly in contact with children, again, I genuinely believe that there is a divide between the two. I think those who are very scared they're going to get it from the children. And then there are those who say, you know what, either I've already had it or I've already been vaccinated, or I can't keep away from the children and I've got to be normal. And they just get on with their normal lives. And in terms of the early settings that you're talking about, what we did see early in the pandemic is actually the risks of infections in those cohorts were actually much lower than primary schools or secondary schools.
I see.
But if you did get an outbreak in an early year setting, it tended to be quite big. And one of the reasons for that is they did not stop interacting with each other and the children. And you can't keep that distance from when they're very young. And therefore, when you did get an outbreak, you tended to get bigger outbreaks. You cannot run an early care setting without that contact. I mean, I presume as a parent, I would be paying them to nurture my child, not to impose barriers and no hands and no touch, because that is not how I would expect my children to be looked after in daycare. So it's a very different philosophy. And I think if you are in daycare, you can't keep that distance from children. And so masking then becomes, like you say, it's a visual prop.
Yeah, well, UK sounding much more sensible than the US right now. Okay, let me toss out some figures on myocarditis and get your take on it. I want to be clear here how to phrase this. I mean, I think for the vast majority of people, adults and adolescents, it's better to be vaccinated before meeting COVID than getting COVID. Okay, I think that's easy. I want to get I ran to get pushed someone out of the line and I got vaccinated. Of course, it's better for me to get vaccinated than meet COVID than get COVID first. But if you happen to have COVID, then I think there's lots of questions that follow, like how many shots you need, we've talked about, and how frequent, etc. And I think myocarditis is a real safety event. I remember where I was sitting when somebody emailed me the Jerusalem Post story saying that the Israelis think it's between 1 in 3 to 5K after dose 2, Pfizer, 16 to 19-year-old boys. And so already we knew a lot. It's not 50-year-old men. It's 16 to 19-year-old men. It's not girls. It's boys. But similarly with J&J and AstraZeneca, the thrombosis was more in girls than boys. So these are all things that can happen. And the moment I saw that initial frequency, my heart stopped a little bit because I say 3 to 5K, 1 in 3 to 5K, that's not a joke. That's a serious. I mean, you're talking, if it was 1 in 3 million, okay, then I'd say I wouldn't be so concerned. But 1 in 3 to 5K, the Israeli estimate made me take note. Over time, we've learned so much. We know Moderna has much higher rates than Pfizer. We know dose 2, if it's stacked with the 21 and 28 day schedule, has much higher rates than if you dragged it out. I mean, I think that's what Ontario province data shows rather compellingly. And so I think in my mind, the goal is to vaccinate people as safely as possible. I think there's some easy fixes. Don't use Moderna if it's a man under 30. There's no need to. You have Pfizer, and we have so much Pfizer, we're throwing it away. We're not going to give it to any poor countries. They're not going to give it to any low and middle income countries. We're just going to throw it away. But that's how, okay. But use Pfizer. The other thing I think is dose 2. I think, I've seen people say that if the person gets dose 1, 16-year-old boy, and they have pericarditis, it's not a contraindication to give dose 2. Are you crazy? You want to give a dose 2 to a kid who just had pericarditis? I mean, what are you pushing it for? I mean, are you going to push it like that? I mean, that to me is just too much. Give it a break, maybe. Okay, maybe cut your losses or maybe space out dose 2. We were very slow to adopt the spacing of dose 2. Some of us have been calling for it since the summer. And then I think the other question is, for a 12-year-old boy, Do they need the same dose as an 80-year-old woman? Can they get by with the 10 microgram dose, the 11-year-old? And similarly, does a 5-year-old need the same dose as an 11-year-old? I think a lot of these dosing is because we assume that if you had more variation in dosing, people would screw up when they're administering it. And I think that's true because my understanding is the most common safety event from 5 to 11 versus 12 and up is that people used the wrong color top tube and gave the wrong dose. But I do think that one of the things that people said was that no matter how bad myocarditis is from vaccine, it's always worse after COVID. And I just think that it's demonstrably false in at least one case. If you have a 16-year-old boy who has one dose in their arm, their risk of myocarditis with dose 2 from Moderna is much higher than if they got COVID in that exact minute. I mean, that's just a fact. And, people can deny that fact as much as they want. It doesn't make it less true. And the goal isn't to not vaccinate people. I think it's to rethink whether or not you need this dose schedule, this timing, Moderna, whether or not it should even be an option. What are your thoughts on this?
So, Vinay, everything you said can't be denied. What you've said is all true. And you have a very strong opinion about this, and it's very clear where you stand on it, and that is fine. A couple of things. One was we were in a slightly worse position in that we had a large population of our teenagers who had already had COVID.
Right.
Now, if you believe that this is a dose effect, then what happens is that your first dose then becomes your booster after infection. Yes. So we were even more worried in our marginal benefits in the beginning that if you vaccinate them, the first dose might have a high rate of myocarditis. God knows what the second dose will do. So we were even more cautious at the time. That's the first thing. The second thing is myocarditis is essentially a clinical syndrome. And therefore, it's only identified if somebody finds it. And places like the UK don't have a really good surveillance system for clinical syndromes. And therefore, unless somebody says this person has myocarditis and reports it to the powers that be, the MHRA, it won't get seen. So if you imagine a person in the UK who has chest pain, they would try and contact their primary care doctor. And if they get an appointment, they're lucky. If it takes them 3 days, by then they'll be better. They're going to go home. They're going to do nothing. If they go to the hospital, they go to the emergency department. We don't do fancy stuff. We might do an ECG in a little bit and send them home if they're well. They're never going to get to see a clinician in the wards or get hospitalized unless they're very ill with it. And so you're only going to get a small proportion going through. And then there'll be the very few who end up somewhere serious with the cardiology interest that will get diagnosed. And so I don't believe that the UK system is actually good enough to identify them. So then you rely on syndromic surveillance and databases, which is an issue. And what you have to assume is whatever rate you are finding at is clinically diagnosed myocarditis. And that is the tip of an iceberg.
Yes.
Where you do get you must have some form of inflammation that accumulates.
Yes.
Now, COVID may cause it, but I agree with what you said in that there is an age-based risk of severe illness with COVID, including heart problems.
Right.
And the younger you are, the less likely you are to have cardiovascular complications of acute COVID.
Right.
We do see it, but it's very rare. Yeah. Most kids, most teenagers do not get cardiovascular complications of COVID, and there might be a small component to it. And most of the studies that are done actually do not separate them by age, which is why there's a fallacy in comparing myocarditis or heart problems in vaccinated versus COVID, because they don't look at specific age ranges like you have done and shown. There's some age groups where vaccines actually cause more myocarditis than COVID, for example.
Yeah.
I think that there is a fallacy. My problem that I see is that the idea that myocarditis is a few days in hospital and then you go home. I find it as a clinician very difficult to reconcile inflammation of the heart muscle. And if genuinely we are saying that this is a dose effect, Pfizer versus Moderna, then perhaps we are giving a very big dose that might be contributing to that. And that's the worry. Why
Yeah.
boys, girls, we don't know,
We don't
hormones
know.
and so on. But at the end of the day, there is an unquantified risk with vaccination,
Yes.
which must be justified by the
Yes.
benefits.
Yes.
And I
And I'll say,
think that
yeah.
is what becomes hard for children because that risk is extremely low, whatever way you look at it. And therefore, any risk with myocarditis, be it small, be it minor, be it temporary, be it, the chances of it ending up with long-term problems is
Right.
tiny. You have to take that seriously because most kids, healthy kids who get COVID, don't end up in the same place.
Right.
And the worry is we might be actually doing things to a generation of children that we're not aware of. That we need to be very careful about how we go forward with what we do with our children because the children have a longer life ahead of them. It's very different making a recommendation for a child who has his whole life ahead of him and say somebody who is 70 and you're worried about VIT, for example.
Right.
And that's why I think the UK, based on everything they saw, could not justify that decision at that time.
That's well put. And it makes me think of a few things. One, the CDC has data from their survey of myocarditis suggesting that like 20% of people have persistent symptoms of vaccine induced myocarditis, even like 50 to 70 days later. We also have MRI data showing late gadolinium enhancement, which is of unclear significance, but had many data sets is linked to poor long-term cardiovascular outcomes. And I'm not saying that's going to happen. We don't know. But it is not inconceivable that somebody who gets it will have some fibrotic scarring and somebody will have arrhythmia. And that is something you have to take so seriously because the alternative was they may have had mild COVID because they're a young, healthy person. And I think that other challenge is that COVID doesn't infect everyone equally. And so hospital records saying what's the risk of getting cardiovascular illness after COVID? Well, COVID has it like a heat-seeking missile. It's finding the people who are already predisposed to those risk factors. That's why they got, in part, why they got sick with COVID. I mean, it targets vulnerable people, people with comorbidities, etc. So these comparisons are always fraught. But yeah, I think it's a troublesome can of worms. The last thing I want to say is when I see people lump together the ages, I get furious. Because the reason I get furious is that, 20 years, every day I open the New England Journal, it's precision medicine, precision medicine. They want to treat you different because you have a different polymorphism than I do, and I should get lisinopril and you should get hydrochlorothiazide. We're all about precision medicine. You mean to tell me, this one instance, you cannot tell a 16-year-old boy apart from an 80-year-old woman? You can't tell them apart, and now we have to lump them all together? It's ridiculous. Of course you can have different policies based on age. There's no rule that says you can't. Why not?
No, I completely agree with you. I mean, a lot of the work that's being done now would never get published in the light of day,
Yeah.
It's just, I think everybody's in such a rush to publish the first thing that they find. And often it takes you down a rabbit hole and it's very difficult to come back. And, classical example is long COVID. Many of those studies should never have taken place because they just took people down the wrong path, especially
Right.
for children. And that's compounded by national surveys, which make things worse because there's no scientific rationale or basis to those surveys. And it's open game for everybody.
They
And
say there's two types of long COVID studies. There's the kind that shows it's incredibly common in children, and the kind with control arms. Those are the two kinds of stuff.
so in the UK,
Yeah.
it's a little bit worse because the UK Office for National Statistics decided to go ask hundreds of thousands of people, do you have long COVID? And basically gave them the freedom to say whatever they want to. If you have anything wrong with you after 4 weeks, you have long COVID. And so if you're coughing a bit, or you're feeling a bit tired, or you don't want to go to work, or it ends up being long COVID. Now, again, coming back to it, those who genuinely have long COVID and are really debilitated by it are lost in the system because there's so much noise that you can't get there. I think the myocarditis issue is we do have to keep a close eye on it. I mean, it's reassuring that so far nothing has transpired. So whatever risks there might be with vaccines are going to be extremely, extremely low.
Yes.
And we have to acknowledge that the vaccines prevent severe disease and hospitalization. And therefore, we are better off with the vaccine than
Right.
without the vaccine. And I think that providing this vaccine to those who are most at risk, especially those with underlying comorbidities, for example, is going to save a lot of lives. And I'm glad we have the vaccines. But I think we're entering a new era where we have new brands coming through that are being licensed. And what we need to do is
Right.
start thinking very quickly about how to utilize these other
Right.
vaccines with, again, minimum harm with maximum benefit. And we're in a good place right now when we shouldn't lose the momentum.
Yeah, no, that's well put. Okay, then my closing thought for you, which I'm curious about, is that I think when all is said and written, one of the defining characteristics, maybe the defining characteristics of this pandemic would be that proportionality thing that you said at the top of this chat, which is that we didn't do enough for the people who needed more. And in this country, that's the older people, and maybe it'll different in your country. But the things we failed to do was initially, there were states in this country that said nursing homes. If a patient has COVID in the hospital, there's not enough room, you're not allowed to block that patient from coming into your nursing home. So we sent people with COVID into nursing homes full of elderly people, like a cruise missile headed into the building. I mean, it's just nothing but casualties as a result. Massively inflating death toll, leading to healthcare collapse. Of course, that was the dumbest thing in the world. And then when we saw that risk gradient, we never leveraged it in this country. We insisted upon one-size-fits-all solutions, even when it was clear that the populace in this country will fatigue very quickly because Americans are not interested in doing those kinds of things for a long period of time. But we insisted upon it, so much so that there's some states in this country, they fatigued in the first 3 weeks and they said they'll never do anything ever again. And so no matter what happened, they didn't do anything, leading to casualties down the road. And then I think the worst of it is that the children, because we close the schools in this country, there'll be some more reports, I think, that are going to be published soon, for so long. I mean, over a year closure, even after it was clear, that it was safe. You could have learned from, Switzerland, Sweden, Norway, Denmark, we still closing. We closed even after the teachers were prioritized for vaccination. We closed even thinking about Omicron, even heard Omicron, and we closed the school again, extended the winter break, remote school, and then the testing. We're testing these kids all the time. Asymptomatic testing. If anyone tests positive, they close the whole class. They wait for everyone to test negative. The testing companies are getting rich, but it's unclear anyone is, getting healthier as a result. And the kids are losing more and more education. And just when I thought that the kids have been beaten enough, then they say, oh, and by the way, if you don't get your 2 doses by the end of the year, we'll throw you out of school for another year. And I don't think it can get worse for kids. And I have to think that the virus didn't do that. The virus didn't say that you have to neglect the elderly and punish children as a result of the virus. We chose to do that. And I think we chose to do that because we didn't move when the evidence changed. We didn't update our priors. We anchored to an influenza mindset instead of a coronavirus mindset. We are extremely politically polarized. We don't even like when scientists have different points of view. Lord, God forbid that we even have that. But that to me, that I think the impact on children will be the greatest harm. And I think it's the last thing I'll say, and then I'll let you talk. The last thing I think it's really destabilizing. Early in the pandemic, John Ioannidis wrote that essay in Stat, and everyone was critical of his essay. But there was one line in that essay that I think was very salient, which is he said that, when you impose restrictions like this for long periods of time, you don't know where the balloon will burst. You could have civil unrest and war and destabilization. You could lose a democracy. And I think history may yet prove him to be very sharp on that point, that he saw it very clearly. Because I think if you have a generation of kids in a country with huge inequity and you make the poor kids even poorer and deprive them of education, make the rich kids even richer, what are you going to do for that society? And so we were never a great society to begin with. We were always much more unfair than your society, and we just got a lot more unfair. And so I think it's terrible.
So I have two anecdotes for you, Vinay. The first anecdote is that actually in the beginning of the pandemic, all my colleagues were busy working on cases and hospitalizations and deaths, and there was all this travel related and strategies to contain them and testing and isolating, and they were all so excited about doing all the adult work. And I was actually twiddling my thumbs, thinking, what am I going to do? Nothing happening with kids. You go to the hospital and the wards are empty. There's lockdowns, and it was really funny that right in the beginning of the pandemic that I decided to take on the peripheral tasks that nobody would do. So I set up a serosurveillance for healthcare workers who were coming to the hospital to bleed them every month, and I'd spend most of my time bleeding hundreds of healthcare workers to try and look at their antibodies and immunity and so on. And then there was an outbreak in an army barracks, and everybody thought it was a really good idea to understand outbreaks and transmission by going into the. So I took a team of my colleagues, nurses and doctors, and we went into the barracks and bled everybody and swabbed them and questionnaire them. And what was really interesting is that one of the senior healthcare doctors who was working with me at the time, public health doctors working at the time, was on call over the weekend in March. And she said, look, we have this whole bunch of PCR tests that we have to use up this weekend. And we're worried that there's quite a few cases in the care homes. So do you think we should just try, and swab a few people in the different care homes, and we have an idea how many care homes are infected?
Right.
And I said, look, that doesn't really make sense. Whether you have 2 or 10 cases in a care home, it's an outbreak. You deal with it. I'll tell you what we should do. What we should do is identify 3 care homes where we think there's an outbreak, and we go in and swab everybody. Residents, staff, visitors, whoever is in there, just swab them all, and we'll do it over a weekend. And I kid you not, by Monday, we were finding 50, 60% positivity rates, even though maybe 5 or 6 of them had symptomatic infection.
I see.
And we immediately, that was the first time we picked up the high rates of asymptomatic infections in care homes, which was then reported upwards. And then all these mitigations came in place, the care packages came in place, the regular testing, and all that happened because of a chance factor that I was on with a person who was on at the weekend. And, I got through experience all that and everything that needed to be done in care homes, because 1 in 4 symptomatic resident died of COVID. 1 in 4, 25%. And it's consistent across many studies, right? If you're asymptomatic, your risk is much lower, but then you are contributing to transmitting. And
right, exactly.
So, there's a lot going on in care homes. So while that was happening, and I was leading at least half a dozen different care home studies, we started the school studies. So I had a completely different view about what was happening in schools at the time, and realizing how different they are. But coming back to you, the other thing was, we always knew this was going to end up with children. There was no doubt whatsoever that this was going to be a pediatric disease, and it still is going to be. It's just a matter of time. And the reason for that is everybody assumed that this was like influenza. Now, the thing about influenza is that you have partial population immunity that goes up with age. So most of the adults and older adults have got some sort of immunity, and the younger ones are still building their immunity. So if you have a pandemic, it will affect those who are least immune, and it will be pediatric. Here we have a virus where the whole population is susceptible, 0 to 100, and it's going to go where people have a lot of contact, the young adults. And then once it's infiltrated those with the most contact, it will then go and attack those who are most vulnerable.
I see.
And it happened to be the risk groups and the elderly. But what you could see very clearly is once it's in and it attacks those, you're either going to end up immune or you're not going to survive the infection. It's going to end up with a population where most of the adults have either been infected or they haven't made it with the infection. And then you only have the kids who will constantly be susceptible as new generations come through. So it was always going to end up in kids. It's just we didn't know how long. So yes, it was disproportionate, but it was very, very predictable that we are going to end up with a pediatric disease, which we will then have to control because they will be the group where the infections will be transmitting within themselves. But the idea is if you protect the most vulnerable, it may be that we have to multiple vaccinate them or twice yearly, then the children can get on with a normal life, just like all the other respiratory viruses that they're used to. And I think that's where we are going towards. And I don't think we're there yet, but we're not very far off.
I think you're right. And I think we'll also probably have the situation where, no matter how you vaccinate children, they will likely to be reinfected multiple times with some version of the virus as they get older. What are your thoughts on that?
So one of the things is that we anticipate, just like the swine flu virus, for example, that this virus is going to circulate and there'll be different variants of it.
Yes.
We hope that the variants will become milder in adults, just like we're seeing the Omicron variant. But there's always going to be susceptible children coming through as
Right.
well. So it's not just about reinfections.
Right. Right.
It's
Right.
also about the fact that there are cohorts that are building up, and every year you get
Right.
a whole new cohort coming through. And that's how the virus survives at the end of the day. And that's how
Right.
other viruses survive. And it just becomes part of the background viruses. Now, the question that we have is, how much do you vaccinate and what are you
Right.
aiming to do with vaccination? So already talks about vaccinating from 6 months of age. Now, if you think about it, when you vaccinated all the teenagers, we were all talking about how much infection is causing in primary school kids. And then you vaccinate primary schools, and now it's all about the under fives.
Yeah.
You vaccinate the 2 to 5 year olds, guess what we're going to be talking about? It'll be the under twos, and then it'll be the under 6 months. And so unless we gain better perspective on what we are trying to achieve, it was never about preventing infection. It was always about preventing severe disease and
Right.
death. And somewhere in the middle of last year, we lost that narrative.
Right.
And that is why we've ended up over here, because we changed the boundaries of what our expectations were.
Mm-hmm.
And I hope that that doesn't filter into children, because yes, you vaccinate children to prevent severe disease and fatalities, and you do that by vaccinating those at highest risk. And I think we should do that properly and focus on that. But then we do have to question what it is we are trying to achieve with constant vaccination of healthy children. And I think that's where the big decision is. This is what's going to come. So you Americans will vaccinate anything that moves. A
Yeah.
little bit
Yeah.
more
Yeah.
difficult, but I think the rest
Yeah.
of the world is moving towards what is it that we're trying to achieve. Many of the European countries have said, we're giving you the vaccine for 5 to 11 year olds, but we're not recommending it. So it's up to you
Right.
whether you want
Right.
it. That's a way to cop out. And other countries like the UK have never really done that, because we have always taken responsibility for the decisions that we make. So we make it very clear that yes, you should, or no, you shouldn't, or this is why you should and this is why you shouldn't, and now you decide. But that's not very often that we do that with vaccines, because the UK, in terms of its immunization program, has been in a really, really good place. We have extremely high uptake. We have a lot of public confidence among healthcare workers and the public health system,
Mm-hmm.
because we are sort of benefiting from the damage that was done with the MMR vaccine and the autism link that was
Yes.
false.
Wakefield. Yes.
And yes, and that did so much damage to our immunization program in terms of academia, media, the news, that we don't want to go back to that place. And therefore, we are not going to take a risk of vilifying any vaccine without good evidence. So the HPV vaccine came with its own trouble. It never really hit the UK because the UK didn't make a big deal of it. And people believed us and trusted us when we said it's not a problem. It is a media issue. If these vaccines weren't safe, they wouldn't come in our program. And we've maintained very high vaccination rates across the life course, and we're quite proud of that. And I just hope that COVID vaccines will not damage that reputation that we've taken 2 decades to build.
Mm. Well, that's well put. I mean, I agree with all that. I mean, I think, um, I think it's not the place for mandates. That's where I think the U.S. oversteps. I think it is reasonable. Different people will view it differently. I think a healthy child, 5 to 11, who had COVID, I think it's a coin toss if it's actually in their best interest to get a dose. But you have your antibody data that and cellular immunity data. So it's reasonable. But do they need 2 doses? Do they need boosters for the rest of their lives? I think that's, we'll all agree that's maybe a bit too much. We didn't get a chance to talk about, but like children who are more vulnerable, it's not exactly the same immunocompromised things you might think about. Sometimes it's slightly different vulnerabilities. I talk to many people. They tell me they're immunocompromised. I say, you may be immunocompromised, but maybe not for COVID-19. Do you want to talk about that for a second? In what ways is it different than the sort of canonical thinking of immunocompromise?
So kids again are very different, Vinay.
Yes.
We don't see that much of an issue with immunocompromised
Correct.
children as you do with adults. What we saw very, very strongly is a risk with severe neurodisabilities.
Correct.
When you have a respiratory compromise in some form, it becomes then difficult to actually get a nasty chest infection and recover from it. And that group, and I'm talking about the very severe
Yes.
neurodisability,
Yes.
always featured very strongly in that group. And then there were other smaller groups that we were concerned about. One of them was Down syndrome, for
Yes.
example, kept turning up in our
Yes.
studies at the time. But when you look at immunocompromised, they are affected in slightly different way. Yes, um, you see a lot of hospitalization among those children who are immunocompromised because every time they get a fever, they need to come in for a full screen
Correct.
and treatment until we know they don't have anything serious. So we saw a lot more hospitalizations. We were much quicker to treat them as well for COVID compared to any other group at all. And so they're affected in a slightly different way. We know that the vaccine may help, but we don't know how much they'll help. But what we see in children with immunocompromise is that the vast majority of them do really well with COVID and recover without any consequences. And that is very different to what we see in adults. We are more
Yes.
worried about we are worried about different groups of children with comorbidities compared to the adults.
Yes, and I think that's an important point. I just was reading a paper about that. Professor Ladhani, I don't want to take up too much of your time, but this was a great discussion. Thank you for trying to find the sensible middle ground in these tumultuous times. I appreciate all your hard work and your efforts at science communication, and people should follow you on Twitter and read your papers. I think that's the best place to start. Thank you so much for doing this.
Thank you very much. It's been a pleasure talking to you.